Hello, everyone, and good morning. I'm very glad to meet you during this panel, which we will talk about problems we have facing to tobacco use disorder in Africa. You know, tobacco use disorder is cost-effective in lives and smoking-related morbidities in Africa. It is now a problem. It will be a big problem in the future. Youth prevalence, smoking youth prevalence is very high, and we are facing many problems. WHO framework programs are not efficient in our countries, and we cannot be able to drop smoking prevalence. We are looking for another way to break and to drop this prevalence, and why we are talking today about other ways to try to give opportunities for smokers to give up smoking, because you know that smoking-related morbidities is due to the smoke. And now on the market we have other products with no smoke, with nicotine, without smoke, and we will try to demonstrate and to have your opinion about other ways to advocate for tobacco harm reduction. We can move to our speaker, Jose.
Good day, Milis.
Yes, good day, and I want you to introduce yourself, first of all.
My name is Kgosi Letlape. I'm an ophthalmologist in private practice in Johannesburg by occupation and a health activist by choice. So I prefer not to be called a health expert. I'm a healthcare professional and an activist. And I'm glad to be in a panel with experts. Now, I think the disclosure would be that I've been consulting to the tobacco industry and been talking to regulators. Professor Rataemane has come on. So maybe, Faris, I should give him the opportunity to speak as a co-chair before I proceed.
Thank you very much. And I just want to thank all the speakers and my co-chair, Faris, for this session. And I think we have a problem that has been outlined by my co-chair of attitude towards tobacco harm reduction in Africa. But it's not just a matter of attitude, but it's also understanding of the problems of continued use of combustible tobacco. But what has also become an issue, and that explains why we have the lineup of speakers that we have, is that there is failure to understand nicotine and its effects on the brain. There are people who understand why some mentally ill patients smoke a lot. They need a nicotine fix, and some people do. But the biological issues relating to nicotine are not understood. So we have a lineup of speakers who are, number one, going to talk about policy issues and approach to policy. Secondly, we have a speaker who will talk about how do advocacy, Prof. Dr. Letlape will speak about the policy issues. And in terms of advocacy, we have another speaker from Nairobi, Kenya. And I'd like my co-chair to introduce the last two speakers and the themes they are addressing and the relevance to this session. Thank you.
Thank you, Solomon, for this introduction. And I think we can give the micro for Jose.
Yeah, I'm an ophthalmologist in private practice in Johannesburg, but I have an interest in harm reduction, and I've been engaging with scientists and experts around tobacco, including the tobacco industry itself. And the last declaration to make is that in beginning of the year, I'm one of 5 commissioners that worked through a grant from the Foundation for a Smoke-Free World to produce a new commission report about reigniting the fight against smoking. And I think what we've seen globally is that there's been an improvement in reducing the number of smokers around the world. Around the late 50s, 60s, the prevalence of smoking in most nations was above 50%. And with the Surgeon General report coming out and there being awareness and more being told about the comorbidities and the lethalness of combustible cigarette, which kill 1 in 2 of its users in their lifetime, you then saw the changes where the smoking prevalence has trended down for most nations. Sadly, we now have more smokers now than we had in 1999, where we had 990 million smokers globally, and today we have 1.1 billion. But the population growth accounts for some of that. We've now seen a stagnation in the decline in the rates of smoking, even in developed nations and in other nations that may have adopted the Framework Convention for Tobacco Control. Now, in terms of regulation in Africa, most of our governments will be informed by what comes from the WHO as a policy framework. Now, the WHO adopted the Framework Convention for Tobacco Control in 2005, and more than 180 countries are signatories to that to date. But what we need to note and understand is that that Framework Convention for Tobacco Control was clearly focused on combustible cigarettes. And the Empower regime that it prescribes is to deal with combustible cigarettes. The nations that are signatories that have adopted those mechanisms are implementing them, have seen a reduction in the prevalence of smoking in their nations. And my country, South Africa, is one of them, of the early adopters. But despite that, we still have about 7 million people that use tobacco at this point in time. But that's greatly reduced from our prevalences that were above 30, 40%, which is now about 17%. Now, why has it stalled? It has stalled because most nations are not adopting all the Empower recommendations, but also because there are people that will not quit. Studies have shown that some people that are diagnosed with cancer will quit for 3 months, and more than half of them will be back to smoking if they are still alive, despite being on treatment. So it's something that is difficult to quit. So the FCTC is a great tool for nations to adopt for combustible cigarettes. Now, the alternatives to combustion have only really come on post-2010 to be popular. Honlik, a pharmacist, reinvented the modern e-cigarette in 2003. Now, if you look at it, the Framework Convention was adopted in 2005. And there were no alternatives really to combustible cigarettes except nicotine replacement therapy, which was only in place because of what Professor Michael Russell said in 1979, that smokers smoke for the nicotine, but they die from the tar. And from that statement, nicotine replacement therapy was born. But now we have many other alternatives based on technology that are alternate supplies of nicotine without combustion. Now, here's one thing that most of us need to be aware of. Snus has been used in Sweden for more than 200 years. Snuff has been in our environment for as long as I can remember. But the Framework Convention for Tobacco Control was not even written to be appropriate for the non-combustible tobacco products that were available even prior to 2000. So what happens when we adopt the Framework Convention for Tobacco Control in 2005? We say, ban snus. That was all that was provided, was prohibition for snus. Now, in the last 40 years, the Swedes have collected information on snus use. One of the key tobacco producers, the company in Sweden, decided to forsake combustibles and concentrate on non-combustibles. The result of that is that we have epidemiological evidence from Sweden about the benefits of non-combustion. We all hoping to reduce prevalence of combustibles to 5% or less in our communities. Guess what? The Swedes have accomplished that. They have a prevalence of smoking of around 15–16%, and only 5% is from combustibles. The other is from non-combustibles. What have they benefited from that? Amongst males, where the use of snus is higher than in females, they show the lowest incidence of disease and morbidity related to tobacco use. Why? Because they've gone to non-combustion. What is the outlook of the WHO on that? Ban snus in Europe. Banning doesn't work. So even though the FCTC is great for combustible cigarettes, there's absolutely nothing for non-combustibles. There was nothing even in 2000 when there were non-combustible products. It has become even more glaring now that there are many more non-combustible products like electronic cigarettes, like heat-not-burn, like pouches that contain nicotine, which are new inventions. And that framework is totally inappropriate to address those. So we need to ensure that our governments in Africa understand that the FCTC is great for dealing with combustible cigarettes, but it's totally inadequate. It was not conceived, and it's not a fault of the WHO. There were no real combustibles. They should be blamed for not having created a framework for non-combustibles of the time. It is now worse because there are more non-combustibles now. So we now need to urge the WHO to come up with a new framework appropriate for the products that are available today. You can't do a cut and paste of the FCTC to the non-combustibles. It just doesn't work, as is shown by the fact that it was wholly inappropriate for products like snus. It's wholly inappropriate for e-cigarettes, heat-not-burn, and the other alternatives that rely on not combusting the tobacco. So we need to advocate for appropriate regulations. And one of the key issues for Africa, cigarettes are cheap. It's to ensure that the regulations that come up don't make alternatives to combustion unaffordable to the ordinary people. Even in first world countries, the vulnerable groups are not liquid. They don't have high economic status. So the issue of access to alternatives is key globally for all vulnerable groups, but paramount in our continent and low to middle income countries. So we need to ensure that we don't hear of anything that bans products just because people are ignorant about them. We need to advocate for appropriate regulation, ensure that smokers can be educated, ensure that the public can be educated, and that the products are readily available and affordable. Misinformation is a major problem. I hope the WHO will learn from the fact that in these days of COVID, they've encouraged governments to rely on science to form regulations. The same thing should be done in tobacco. And I can't not compare the parallels where smoking kills 8 million people a year globally. COVID has killed 4.5 million people in nearly 2 years. Smokers matter. Smokers are human too. So let's encourage our governments to understand that we need to write new regulations based on science, based on relative harms caused by alternative nicotine delivery. I'm a physician. If nicotine was the problem, why would we have accepted nicotine replacement therapy? Lastly, on misinformation, you can see in the COVID pandemic that those that base their approaches not on science are called anti-vaxxers. Vaccines work, but we still have a low uptake in some countries, including mine, because of the misinformation. The irony is that with tobacco, the misinformation is propagated by the WHO, and it's an encouraging governments to spread misinformation. In my country, a questionnaire revealed that more than 70 people think that e-cigarettes are more harmful than combustible cigarettes, something that has no truth. So I'm looking forward to the discussion, and I hope we will ensure that our governments understand that FCTC is great for combustibles, but it is not appropriate for anything else that is not based on combustion, including old non-combustibles like snus. Thank you, Faris, and I'm looking forward to a fruitful engagement at the end.
Thank you, Dr. Letlape, for a very informative presentation. We will take questions after all the presenters have presented. Faris, please continue to introduce the next speaker.
Okay. We have Iman Candidi from Morocco. She's a psychiatrist, addictologist, and head of the Addictology and Associated Pathologies unit at Clinic Andalus, Morocco. Please take the micro, Iman.
Thank you. Thank you. I am very happy to be with you today. Thank you, Faris. You are a friend, you know, and I'm very proud to help today to think with you about harm reduction and tobacco harm reduction and depression or mental illness in general. So we are talking about harm reduction, about tobacco, about mental illness, and we know that people with mental illness or patients in psychiatric units have big consumption of tobacco, and tobacco use in people with mental illness continues to be the subject of increasing. We have decreasing rates for people who is smoking, but with people without mental illness, but for people with mental illness, and especially for psychiatric units, we have more people every year smoking, and I think psychiatrists and the physicians who are working with people with mental illness, even if it's not in the hospital, don't think about this fact, because it's like if it's secondary things, it's not very important when you have schizophrenia or depression or anxiety. We are always focused on the mental illness and not tobacco or other substances. But it's very important to have to make the link between nicotine, cigarettes, conventional cigarettes, and depression or anxiety or schizophrenia or bipolar disorder. And we know that we have many depressions in many depressions or depression in bipolar disorder or depression disorder with the type 2. So it's important to make the link. The link is biological, the link is neurobiological, the link is pharmacokinetic, and the link is with the psychotropes too, because it's important to know that when we give to people psychotropes, I don't know, neuroleptics or antidepressants or anxiolytics, when you give them and when they smoke, we have the rate in the blood of the medicine is decreasing, and it's difficult for people to have the good rate of the medication and we are supposed to give more medicine, and it's however. So smoking and smoking-related illness are extremely prevalent among people with mental illness, and significantly, it's increasing and increasing in Morocco. In hospital, on public hospitals, we are not talking about this, but we have to know that people with depression, we have a link, strong link between depression and tobacco and nicotine. Why? Because it's dopamine and serotonin pathways. Dopamine and serotonin pathways contribute to addiction, but not just to addiction, to depression and anxiety and other mental illnesses. It's important to know that when people smoke, when the nicotine in the brain increase the rate of dopamine, so it's the pleasure, but decrease the rate of serotonin. Serotonin is responsible when the rate is decreasing, when people, even if it's genetic, when people have a lower rate of serotonin, they have anxiety, panic attacks, obsessional troubles, and depression. And when we have a chronic nicotine exposure a long time, it's very difficult to know if the symptoms of depression are caused by the nicotine withdrawal, or but a real depression with symptoms of depression. It's very important. There is other things too, because I'm talking about nicotine, but nicotine is not is a problem for addiction, but it's not the problem for organic problems or for cardiac diseases or other things. And we know that people with mental diseases, how to explain, they are not always able to hear you or to speak to you about their addictions. They are able to talk about depression, about anxiety, about panic attacks, about problem of insomnia. But when we talk about cigarettes or conventional cigarettes, they just look to you, look at you, and tell you, but it's my best friend. What do you want me to do? I lost my job. I have problems with my family. I have problems to make a decision or to have a decision. I have problems in my environment, and you want to remove my only best friend in the world, because you know there is loneliness and something very difficult to manage when we have a mental illness. So we try in a small unit. We have a pilot project in a small psychiatric unit in private practice with just 20 patients. We try to give them a heated tobacco device, and we try to give them electronic cigarettes to know if they can manage their addiction or their consumption with something with lower risks for their health. So we constate some things. With electronic cigarettes, we have people not able to, they don't have consciousness of their, to count how many times they have the electronic cigarette every time. And with sticks or with heat tobacco, it's more easy for us or for nurses to know how many cigarette sticks or how many sticks or of heat tobacco they consume in a day, and we can manage this because, you know, when we have people in hospital or private unit or in psychiatric unit, we give them a number of cigarettes a day. It's between, it depends, but it's between 8 to 15 cigarettes a day. It's 1 cigarette per hour, something like this all over the world. So it's difficult for us when you give electronic cigarette to stop a patient, especially if it's a big disease or a heavy disease, and to count with them or to help them to be conscious of their consumption. With heated tobacco, we noted that that we can manage them. We can manage the consumption, how many heat sticks they have a day, and these people, because it's difficult to manage with the psychiatric patients sometimes, and we can understand them, because sometimes it's very difficult to manage themselves with their many diseases, or when they have I know, black ideas or something like this, and it's difficult to talk about organic diseases or organic risk or addiction when people is suffering. So we make a questionnaire, you know, to understand if they are better with the heated tobacco devices, and their responses were yes, it's like tobacco, but I have like cigarettes, I have sticks, so it's not like electronic cigarettes. I'm better with this product and not this product. We just try to switch. We begin this since just 4 months. 4 months, and I'm trying to find I don't know if I have it here. We have 43 people with heated tobacco devices, and for 43 people, after their hospitalization, after 2 months, we keep 15 with just who switch directly to tobacco, heated tobacco, and stop definitively for these 2 months the conventional cigarettes. For the others, sometimes it's conventional cigarettes, and sometimes it's heated tobacco. So even if it's just 15, and we have 43 persons, it's important, because we are still working with psychologists and about psychoeducation. It's important for them to understand and to balance between advantages and inconvenience of things. And for people with the problems, because we have people with problem of with diabetes or with cardiac diseases or blood pressure, we just explain to them that there is many risks for health, and to switch to heated tobacco is things like lose weight, or like not eating too much sugar. We can reduce risks of morbidity and mortality. So people, that's 15 persons or patients who continue with heated tobacco devices, were people who are every week present to psychoeducation, because we have a group every week for people who want to keep a link with the team, with the nurses, with the psychologists. And when people is coming every week, we can explain, and we can, it's like we need to repeat and repeat to fix things in the brain of the patient, and it's better for them. For some of them, tell us it's better for me when I can make sports, I can run. I couldn't run before. Something like this. So it's just the beginning of this little study, but we are expecting that that this pilot project.
Sorry to interrupt you, Imane.
Sorry.
Sorry to interrupt you.
Yes.
We have 7 minutes to go, but may I ask Joe Murillo to please switch off his camera until the session comes up.
You don't have, okay.
No, I'm asking the people in the next session to switch off their cameras. That's fine. Please continue.
Okay. So I hope that we will try to set up a smoke-free unit. We don't need just one smoke-free unit. We need to help and to try to do it in public hospitals, because we have too much patients in public hospitals. It's not like private unit, just 20 or 30 patients, and it's not the same social and economic people, so it's different. And I think it's important to sensibilize. It's important to talk about this. It's important to use medias or every support to talk about harm reduction, especially about tobacco, and it's important to explain to people what they can win by these devices, because it's not just white or black, or it's not like this. We can just yes, you can smoke. I have some physicians, some friends and some colleagues. They dichotomize everything. It's just black or white. You have just to stop to smoke if you want to be good, or if you have a cancer, or if you have a problem, any disease, and if you don't stop to smoke, but you have not to come back to me, because I can't help you. It's important to be human with the human, because human is just a human. We can just like physician or any physician, not just psychiatrist or a cancerologist or pulmonologist. My friend Ferris is here. We can just talk to people and tell them, you have to stop to smoke, because if you don't stop to smoke, you will have disease, and you will die. We can talk to people like this. We need to adapt our words. I think we need to talk to physicians. We need to make courses for physicians, how to explain to people, how to give a third way to people to be in better health, to be aware of his health. And harm reduction is the solution, not just for tobacco harm reduction, but with the COVID-19, we see that harm reduction was the solution, because if we look to the lockdown how we manage it, or the vaccine, etc. It's harm reduction solutions. It's not the reanimation and the Temra and all these things, the solution, especially in our countries or in Africa. So while in ready, it's important to replace everything in our culture. I'm talking about Maghreb culture and African culture. It's important to talk about modernity, because if in USA conventional cigarettes are has been, in our countries it's a symbol of modernity, even if it's bad for our health. It's important. I talked before about neurobiology. It's important for me, I think, like today, and I'm very thankful for this, to find together how we can prevent, initiate, and try to make aware people in governments and to have new public policies, public health policies about tobacco harm reduction, about harm reduction in all ways of health, even if social health or even if we talk here about social health or economic health or anything, because I think harm reduction is the new way or the third way or the fourth way for Greece to think about the health or public policies for tomorrow, especially in our countries in Africa. And we need to open mind our governments about this. It's very, very, very important. Thank you. Thank you so much to invite me today. And I will share my presentation with you if someone wants it, because you know, psychiatrists listen every day, but when you give them to talk, they can't stop talking. Thank you so much.
Yeah. Thank you very much, Imane. So the next speaker who's going to look at the need for a harmonized or unified approach to harm reduction is Uta Ouali from Tunisia. May I ask Faris to please introduce her properly?
Yes, first of all, thank you, Iman, for sharing with us your experience with the smoker population and the psychiatric comorbidities. It's, I think, very interesting, and we'll talk about that if we will have more time. Now, I invite Uta. Uta is a senior psychiatrist at Hospital Ghazi in Tunis. It's a lecture in the University of Tunis in Manar Medical School. Uta, you have the mic.
Thank you very much. Very glad to be here with you today. Thank you very much, Faris, for inviting me. So yeah, as you already told, so I'm a psychiatrist too, in the main mental hospital in Tunis. So, and it's a public hospital, on the contrary to Dr. Candili, who is working in a private setting. So I could really very well relate also to what she just said about the difficulties treating patients with severe mental illness, because this is also mostly our inpatient population and the difficulties they have to quit smoking. We also know that patients with severe mental illness very often have difficulties or have comorbid other substance use, and so this is going to be the objective or the subject of my presentation. So I would like to share my screen with you now. Can you see it? Can you see the screen?
Yes, yes.
Okay. Perfect. So I'm going to talk about the specificities of tobacco and other substance user, and why we think that there is a need for a unified harm reduction approach. So, sorry, I think it doesn't. Yeah. So now, what are the difficulties that tobacco and other substance users face? In fact, now what we already know is that the rates of smoking are 2 to 4-fold higher in people using other substances, and that also persons with substance use disorder are much less likely to quit. So I have some numbers here. For example, the quit rate among smokers with no history of psychiatric disorder or substance use disorder was 42.5%, which is quite high, but there were significantly lower quit rates which were associated with alcohol use disorders, like 17% or even less. Now, over 75% of alcohol and drug dependent persons in early recovery smoke cigarettes. And in general, they tend to be very heavy and highly nicotine dependent smokers. Also, what has been found from several studies is that cigarette smoking increases the likelihood of relapse in people with substance use disorders. Now, just to confirm what I just said, you see here a graph of the prevalence of cigarette smoking in clinical samples of Indian individuals with psychiatric disorders and substance use disorders. And what you see also, what is interesting, that although the prevalence in people with psychiatric disorders is already very high, now the prevalence in people with other substance use disorders is even higher. So you're being even more than 80%. Now, what's the problem in people with substance use? The problem also is just like in psychiatric disorders, that there are neurobiological modifications. In fact, that have been taking place due to the repeated substance use. And so what animal and human research has found is that there is a reward system dysregulation, stress system deactivation, and prefrontal cortex impairment. And all these factors, in fact, impact on the possibility to quit smoking. Now, a bit more on the relationship between tobacco use and substance use disorder. Now, what you have, just as in psychiatric disorders, there are intrinsic factors such as shared genes, abnormalities in the brain reward pathways that predispose individuals with substance use disorder to smoking. And what's more, you have a very high comorbidity with cigarette smoking in patients with dual diagnosis. So building on what Dr. Kendili just said, so in people with psychiatric disorder and substance use disorder. Also, people with psychiatric disorder, but also with substance use disorder, tend to use nicotine to self-medicate their symptoms. And also what has been found is that nicotine administration through cigarette smoking modulates several neurotransmitter systems, just like the dopamine system and the serotonin system, which is thought to be involved in the pathogenesis of substance use disorder. Now, what are the most frequent substances that are used with cigarettes, according to recent studies? But I could also extrapolate this to the context, like in Tunisia. So you have alcohol, but you have, above all, in Tunisia, really cannabis. And why is there this very frequent comorbidity? It's because tobacco and cannabis share common environmental factors and smoking cues that might really contribute to this sustained use. And also what has been found is that alcohol and tobacco use increase the cravings for one another, suggesting underlying biological and physiological mechanisms. Now, what can be done about it? And here's my advocacy for, in fact, a more unified harm reduction approach in the context of people who are substance use disorder, who have another substance use disorder, and who do smoke cigarettes. Now, as we all know, there have been harm reduction strategies implemented, and they have shown to be effective, especially in people who use injectable drugs and also people with alcohol use disorders. And in many groups, or especially subgroups of people, abstinence, in fact, has been replaced through these harm reduction strategies. And these subgroups of users are especially polydrug users. These are people with psychiatric comorbidities and socially and economically marginalized groups. And we think that people with tobacco use from these subgroups, at least from these subgroups, should benefit from the same type of harm reduction strategies. And this could be the use of snus or other oral tobacco products. As an example, in Tunisia already, and this was there's a traditional use also of oral tobacco products, which is called MEFA, and other harm reduction approaches could be the use of heated tobacco products or e-cigarettes. In Tunisia, the problem is, when I talk about especially people going to the public hospitals, so you have the socioeconomic levels, which is quite low, and which makes it very difficult for people, in fact, to buy e-cigarettes or heated tobacco products, and it's not something which is included like in any health insurance system. Now, of note, so for tobacco harm reduction, in fact, a partial substitution is generally ineffective. So substitution should ideally be complete and sustained for effectiveness. Now, to conclude, I would like say once again that substance use disorders are very important contributors to the high rates of tobacco addiction, and smokers with these comorbidities demonstrate lower rates of quitting compared with smokers in the general population. Therefore, a unified harm reduction approach for both substance use disorder and tobacco addiction could therefore be an effective means to reduce risk, which are linked to both types of addiction. And I thank you for your attention.
Thank you very much, colleagues. I thank all the presenters, and it's a pity that we didn't have a perspective from the consumers, from Joseph Magero from Kenya. But before I hand over to Ferris to take the questions, may I just ask Dr. Letlape to give us a summary of what would be the possible issues that Joseph Magero would have talked about in relation to the consumer perspective on tobacco harm reduction. Dr. Letlape?
I think what Joseph would have spoken about from a consumer perspective is access to credible information that is truthful on products themselves and the risks that they pose. And more importantly, availability of products. As you know, from his environment, there was an increased take-up of nicotine pouches. And suddenly the government clamped down on them and restricted access to those without an outright ban. So those would be the concerns where consumers need to be given credible information. They need to be able to make informed choices, and governments need to ensure that there's availability of the different products. And I think those would be the key issues. Deal with misinformation, make products available, make them accessible. And one of the key challenges that you would have probably spoken about, if you look at the FCTC, part of its recommendations is about cessation programs. When you look in Africa, there's a clear non-availability of those. There are very few countries that offer cessation in their health programs that are available to the public. So we'd need an increase in those. But even in those cessation clinics, you'd need them to be open to what appeals to smokers. Don't give them what they are not going to use. Move away from quit or die. And those that can't quit need to have access to alternatives that are safer than the combustible tobacco. I guess those would have been the two key issues. So taxation would be a key issue because a huge component of the cost of cigarettes is tax. So we need to apply a different tax regime to the less harmful products so that they can be price competitive with combustible cigarettes. Otherwise, people won't switch because they don't have the money. They'll stick to the cheapest product that's readily available. And availability in the market is going to be key because cigarettes are easily available from informal vendors, from shops, from anywhere you can get cigarettes. And we need to ensure that the alternatives are also readily available. I think those would be the key issues that would come from a consumer perspective.
Thank you. Ferris, we are requested to summarize and close the session now. Let me hand over to you.
Yes, thank you very much for all speakers. We must, and we have some late. We are late to, and we must conclude. Thank you everyone for your attention. And I want just to tell you good news. After almost a decade of incidence of smoke-free alternatives on the black market in Tunisia, Tunisia has currently made good progress when it comes to formalize harm reduction policies and regulating electronic cigarettes and heated tobacco products, which will allow the conversion of about adult smokers to switch to such better alternatives. And some of the question we must answer it from discussion. How can we convince policymakers to implement tobacco harm reduction in Africa? My opinion is that scientific associations have a good opportunity to do that and to advocate for that. Thank you, everyone, for your participation, and thank you again for speakers for their participation, and I hope to see you again next time. Thank you very much. And Solomon, you have something to add?
No, thank you very much. You've summarized very well. Thank you.